came in vain. The one thing I would like to sort of highlight was, my hospital is a very well-funded private hospital in the center of Manhattan. Manhattan, being both the smallest and the least populated borough, has the highest proportion of ICU beds and the highest proportions of private and university-funded academic medical centers. Whereas our affiliate site, which is Elmhurst Medical Center, which many people may or may not have recognized from a lot of the news coverage, which is where myself and my colleagues have rotated for a month of year every year, is the Safety Net Community Hospital in Queens, one of only 3 or 4 safety net hospitals in that community, which has, about double, if not 2.5 times the population of Manhattan, but an infinitesimal relative amount of ICU beds and capabilities. My colleagues who were at Elmhurst weren't so fortunate of having the funding and the uniform organization that I was at Mount Sinai, because of numerous bureaucratic barriers and poor foresight and sort of endemic issues for a long time. They unfortunately had to care for a large wave of individuals, often very sick, without the appropriate both protective equipment as well as medical supplies. There was a lot of mortality very early on, unfortunately, for causes that weren't necessarily related to COVID, because they weren't able to get certain things that they required. For instance, patients would go into renal failure, both as a result of coronavirus or from a pre-existing condition, and we didn't have appropriate dialysis machines at Elmhurst to care for all of the people who need it, and unfortunately, it led to a lot of unnecessary death. All of this was happening throughout the end of March through April, with varying changes to what guidance was present for us for what masks we should wear. At first, our hospital was stringently adhering to the CDC recommendations at the time, which, if you remember, they came out famously saying that scarves were sufficient and various makeshift face coverings were sufficient and appropriate, which, in hindsight has turned out to be not necessarily the case, but it's very unclear. And we had to fund and resource our hospital to resource masks and gowns and gloves and appropriate PPE from other sources. We also had no understanding or guidance on therapeutics and how we treated these patients. Beginning, we were treating pretty much everybody on hydroxychloroquine, which has been very controversial, to say the least, at this time. And for context from the medical evidence side of things, the original paper that was published showing benefit of hydroxychloroquine was a study done in France. I think it was a total of 20 to 30 patients, many of whom were excluded because they became too ill. So the final analysis didn't even include the sickest of the sick. And the publication that eventually published the paper a month later wrote a letter effectively retracting the paper, saying that that paper didn't meet the criteria of peer review and there was enough flaws that it should be effectively disregarded. Now there's been enough overwhelming evidence to show that it's been ineffective, and also more evidence to show that it's been independently harmful. Unfortunately, at the time, sort of based on a lot of medical inertia and a lot of need to find some kind of therapeutic for these patients, a lot of patients received this therapy, and it's hard to know if that was negatively impactful of their outcomes or if it was contributed. Unfortunately, a lot of these things are going to have to be seen retrospectively. One thing we also found was many of these patients were having blood clotting disorders, whether they're having strokes, whether they're having blood clots in their lungs. So eventually patients were becoming anticoagulated with medication that thinned their blood to prevent blood clot formation based on the anecdotes that we were seeing. All of this led to papers coming out recently. There was a lot of publications in the news about this paper that came out showing that there was a benefit. That actually paper came out of Mount Sinai. A colleague of mine wrote that paper showing that there was some benefit with this drug. It remains to be seen, though, if that was the case, and it didn't come with undue risk. All of this is to say that during sort of the most challenging times, we had to pull in all hands on deck. We had to rely on our observations and what little data we had to make very difficult decisions for these patients, as well as rapidly train staff to overcome the large burden of the amount of patients who are coming in. For my personal program, the residency, the medicine program, we usually are the ones who exclusively take care of patients on the medicine floors, but because of the high volume of demand, we had to recruit doctors from other subspecialties who ordinarily wouldn't be taking care of these patients. I was at one time when I was on a night shift, I was overseeing 3 orthopedic residents, a few radiology residents, some OBGYNs, some pediatric residents, various NPs and PAs from different subspecialties, whether inpatient or outpatient. Everybody doing their part, trying their best to contribute, but also unfortunately lacking the experience and sort of the guidance necessary to really take care in this context. But everybody sort of had a very strong collective mindset, and everyone was willing to learn, and everyone banded together to really pull this together. Really, to the credit of our medicine department and our leadership in Mount Sinai, I'm very fortunate to be working there, because I think the way that they were able to expand and able to gather appropriate resources in a very short amount of time with very little guidance was very commendable. Unfortunately, that didn't necessarily trickle down to other institutions that weren't as well funded or organized. So over time, we had patients who, for context of what a patient who has COVID-19 looks like, the predominant features of most patients tend to be older, tend to have other comorbid chronic medical conditions. But I personally took care of patients who were as young as 21, 22, and as old as 100. The varying complications really affected every single organ system. A lot of things that aren't as well published in the media yet, because there's still a lot of investigation, is the effect of the coronavirus on the kidneys, on renal failure, the effect of coronavirus on the brain beyond just stroke events. People become very confused, have a lot of neurocognitive deficits. The effect of coronavirus on the pancreas and the hormonal system. Another thing that's under a lot of investigation is people developing diabetes, very, very severe florid diabetic complications after not having diabetes, who are COVID positive. There's a lot that's coming out and that's evolving. The most challenging part, though, given all of that, was that these patients had to be isolated, both from each other, but also from their families and their loved ones. I'd say the biggest challenge, and the thing that I've had to grapple with the hardest, that I'm still trying to articulate, was the phone calls I've had to make with families and patients, loved ones, where both anticipating bad outcomes because these patients, their oxygen can decrease so rapidly, and we had no predictive measure of whom it would be or how it would go, that we were trying to be as aggressive and anticipate these things with families as much as possible. But many of these conversations had to be done over the phone, had to be done with a phone translator, oftentimes had to be done during a very acute situation where someone was actively decompensating, requiring higher level of care. And my first interaction, covering at night or picking up a new patient, introducing to myself to a family, was explaining that their loved one was in a very dire, critical illness, and decisions had to be made rapidly without a lot of context, and we needed guidance on that. That, I think, is really one of the main tragedies of this whole thing, is that so many people who went through the hospital and were discharged or who passed away had to endure their admission by themselves in isolation without their families present for that. And I worry sort of the long-term aspects of these things, sort of the mental health toll that's going to take in addition to the physical health toll. So that's been, in a nutshell, what my experience has been. To bring it all together, to put a point that I think is positive. The degree, and as scary and as hard and as bad as I've made it out to be, and have tried my best to convey, the amount that the public and everybody has taken this so seriously, at least early on, with social distancing measures, with, washing their hands, wearing masks. There was a study that was released from the Canadian Medical Association that was looking at, I think their total patient population was 300,000 patients globally in different pockets of the world. And they were looking for which specific variables led to the most profound reduction of cases. They were looking at different climates, whether they were in a tropical climate, they were a warmer climate, whether humidity played a role. They also looked independently at different social distancing and public health efforts, namely closing schools, large-scale business shutdowns and canceling of public gatherings. And the only measure that they found in this very large population that was actually significant in case decline were social distancing and canceling of public gatherings and a lot of these efforts that we've been partaking in. And truly in New York, the success that we've seen is fully and entirely a result of the collective public's taking this incredibly seriously and taking this pandemic as something that requires full buy-in from everybody in the community. Without that buy-in, it's hard to know and it's hard to anticipate how bad it could have been, relatively speaking, and if we would still be in that relative surge state that we were in about a month and a half ago. I'm very thankful for that. One of the questions I'm sure I'll be able to answer is a little more elaborating on that. I'd be happy to do that, especially in the state that we're in right now, some best practices moving forward. But I think that is really the one takeaway and sort of that's given me a little bit of pride and, faith in our collective ability as humankind, that we have the ability to mitigate something like this to the degree it could have been, as best we could have been. So I'm looking forward to answering all of your questions. I want to be, the most, useful resource as possible. I find that, many of the things being reported in the media are things that, within the medical community, we're seeing weeks ahead. So I want to make sure I can be as up to date and as thorough for all of you, because things are moving at a breakneck speed. And I'm very thankful I could be here and speaking with you guys, albeit not in person. But I am yours, and I'm more than happy to help.
Well, Aaron, thank you so much for kind of that perspective. It's really incredible. Again, to our guests, if you have any individual questions that you want me to pose to Aaron, don't hesitate to chat me directly. But we have a number that were already sent in prior to the event that I'm going to pepper Aaron with now. And the first one, Aaron, is about vaccination. And as Bill Gates recently came out with a comment, do you believe that vaccination is the only preventative measure in order to get back to normal?
Yeah, so the concept of normal is very interesting, because I find that oftentimes the language we use as describing, open versus closed, normal versus abnormal, as very binary, as, anticipating what life's going to be like. It's as I really want to be as hesitant as possible to say that there's going to be some magic light switch that we flip and everyone's going to be able to, resume life as usual. As far as vaccination is concerned, as if there is anything that we can be uniformly say that would, prohibit the amount of spread and pretty much put the COVID-19 behind us so we can fully move on, would be development, distribution, and mass efforts to have enough people in the entire world vaccinated to minimize the amount that it wouldn't be able to be spread, basically induce herd immunity. Now that is based on a number of factors and obviously a number of barriers. Right now, vaccines are in stage 2 trials, which is the most recent trials, which is the phase where they're testing it on small numbers of human subjects to determine if it's efficacious. The first phase that they went through that got a lot of publicity basically was, did we give them the vaccine and terrible things didn't happen, which is good. I'm glad that, the vaccines that they're trying so far haven't caused horrible side effects that have made them unusable. That's really reassuring. But from the information I'm gathering, a lot of the targets from these vaccines that they're targeting, a lot of the specific viral particles are in line with the antibodies that patients are naturally developing after they've been infected. Specifically, there's this, a virus is just much a bag of DNA and protein, the specific protein on the virus itself that, all the antibodies that we're testing for are targeted for that. So there's a presumption that people who develop immunity with a similar mechanism as what they're trying to target with the vaccine. So that is technical, but very reassuring, both from the medical and public health standpoint. But that's also not imminent. So to bring it back to how we are now, the reason for social distancing and what was so important about social distancing and everything we did was to remove everybody from exposure for people who had COVID-19. So the people who had COVID-19 their disease would run its course while minimizing the spread to other people. So as it would go, everyone who has it would no longer be contagious, would let it run its course, and then the relative community exposure would go down to such a degree that it would be less of a concern. The way to sort of ensure that people can rejoin the community and feel comfortable in the time between a vaccine is developed is to have robust testing systems in place, and from the testing systems have the ability to both recognize people who do test positive, have them isolate for an appropriate amount of time, and the word we hear is contact tracing, which is quite literally find out who they were exposed to and also isolate them as well. So that I find is the main barrier to resuming some sense of normalcy, because what that provides is the ability for doctors, public health experts to appropriately mitigate the concern and reduce outbreaks before they become so vast and so widespread that people in such close quarters that spread very rapidly like it did in New York. So while a vaccine is the be all end all, I'm confident to say that that's not the last and only vestige to return to some sense of normalcy. A lot of the efforts to ramp up testing, ability to have contact tracing on a large scale, albeit more of a local scale, that's kind of been very segmented, is the path that's going to help allow people to regain some normalcy in their lives. But it's not going to be without probably wearing masks, mitigating risk of exposing other people, continually encouraging hand washing, having social distancing measures in place in varying businesses and varying places. But it will allow people to go back to work and regain some normalcy and offset a lot of the economic problems that came with this whole pandemic.
Thank you for that. Another question that came in from one of our guests is, what have the medical professionals learned since releasing information on the pattern of strokes?
So one thing that was publicized a few weeks ago, if not a month ago, is that a lot of young patients were coming in with strokes found to be COVID positive, patients who had no normal risk factors or chronic illnesses. The one thing that we're seeing is, beyond just the strokes themselves, we're seeing blood clots forming and causing a lot of the major pathology we're seeing in very different parts of the body. There was actually a few days ago, a paper that was released in the New England Journal that was looking at autopsy data from different patients who were COVID positive, comparing them to patients who had H1N1 flu, both from the outbreak in 2009 and also 1918, which I don't know how they got a hand of those lungs and those tissue, but they did. And they looked at a lot of different things, but one thing that was consistent was a very, very, very large burden of blood clots in the small vessels of the lungs compared to patients who had the H1N1 flu in 2009, and also a large degree of vasculopathy, which is changes in pathology in the blood vessels causing swelling and new blood vessels generating, which is pathologic and very new. We're finding that patients on dialysis are having clots in their dialysis filters, or having large frequencies of pulmonary emboli, large frequencies of clot found in their livers. It's sort of becoming understood that a main driving force of the pathology we're seeing with COVID-19, especially in the most severely ill, there is some component of clotting, and stroke is one of them. That's why we're trying various therapeutics with empiric blood thinning, which has its own set of dangers, high risk of bleeding notably. But it's a very, very keen point of research. It's actually one of the projects I'm currently working on at Sinai. It's something that's a big focus.
Okay. Could you speak to your personal anticipation of a second peak in the fall or the winter, and how that might be impacted by temperature and things like that?
I think temperature is not something that's going to affect this at all. What I think is the one thing that's concerning is that this virus has almost a perfect storm of infectious properties, in that people who have the virus and are shedding the virus and are contagious don't know that they're contagious for 5 days, up to 10 days, 2 weeks, in some cases. And so as we open up and as people, decide to not wear masks and decide to not, appropriately social distance, um, one person or a few people exposing a number of people who may or may not develop symptoms, we don't see the full extent of that until 2 weeks after that exposure. So thinking about it mathematically, sort of one person exponentially exposes 50 people, those 50 people, another 50 people, but each of those 50 people have about a 2 week timeline before they develop symptoms, and then on and so forth. So really, truly, we don't really know what we're going to see until more people start opening up and more people start exposing and loosening restrictions. Based on the pattern that occurred in New York, the amount of time from first case to full-on surge was about a month and a half. So we're starting to see more cases and more of an uptick of cases in different places. But what's reassuring is that life isn't 100% as normal, and why there's all these scary images of people at beaches and at bars and everyone's very close together. The general life that we're all living in, the general public and the massive population, we're not intermingling in the same way as we were in New York City. We're not riding the subway, riding buses, not wearing masks, sitting in crowded bars and crowded restaurants, working in large office spaces. Those things just aren't happening. And even partial mitigation efforts and enough people within the population adhering and being diligent about distancing and reducing their own risk of exposure and exposure to others is still better than where we were. Unfortunately, it takes only a few bad apples to spoil the bunch, and so it remains to be seen to the extent of what these things will show. And my concern is that by the time we really see the wave coming, I think we'll know more at the end, like around July, August time. It'll be challenging to dial things back and sort of undo what has already been done because of that latency and when people develop symptoms. So will there be a peak? I think it's inevitable as we reduce all of these measures that we have and people are starting to regain some sense of normalcy. But I think if we have enough contact tracing and testing capabilities by that time, it won't nearly be the same severity as it was in New York. But I'm very cautiously optimistic, but it's very hard to know.
We've had a couple questions, Aaron, about testing and the research on the sensitivity and specificity of the COVID-19 tests. How likely it is to have false positives and false negatives. And do the antibody tests as they stand now indicate that a person would be immune to the current form of COVID-19? If you can comment on that.
So I'll answer the antibody test first, because that is something that, in an effort, I feel like it was a reflexive effort because testing for the actual virus itself was so slow. We shifted nationally the other way of really trying to make a push to get these antibody tests as fast as possible. Whomever was able to develop one got rapid FDA approval, and they were out in the community. The problem is they didn't undergo the same degree of scrutiny. They didn't have the same level of testing, and they also didn't have a positive control, which is, to compare this test to really understand the sensitivity and specificity, because we don't know what we're even comparing it towards. So it's hard to even capture what each individual antibody tests convey, because it's hard to know which test is actually being done in different places. And also, as far as immunity is concerned, it's presumptive that antibodies convey immunity. We're testing for antibodies, but it's hard to know if we're testing for those antibodies that convey immunity, or even if the test that we're testing for is accurate or not. So that is a big mess, and it is challenging to really have confidence in antibody testing. At Mount Sinai, since we're one of the leading centers in the convalescent plasma trial, our antibody tests not only measure positive or negative, but we directly quantify the amount of these specific antibodies, and they're a collection of multiple different antibodies that has more of a degree of accuracy, because there's that two-pronged, both quantitative and qualitative approach, but that's not necessarily what's out in the community as of now. And as far as the actual PCR testing, where we're putting swabs and scratching people's brains, and it's very uncomfortable. Personally, in our hospital, the number has been tossed around is the sensitivity is 70%, which is the amount of patients who have the disease that will actually be detected by the test is 70%, so 7 in 10. I personally have had multiple cases of patients with COVID who have all of the characteristic lab and imaging findings and symptoms, who we've done tests up to 4. I think the record in my program was 8 times, and still couldn't convey a positive result. Mainly is because it's testing the presence of viral RNA in the nasopharynx or the oropharynx, so in the mouth or in the nose. So there has to be either shedding virus or residual RNA present in that particular space in order to convey a positive test. And typically, we, based on more data that's coming out, the actual time of viral shedding is about 1 week, with residual DNA about 2.5 weeks. So if someone's initially developing minor symptoms, developing more severe symptoms, typically patients who develop the more pneumonia-like syndrome are symptomatic for anywhere up from 7 to 10 days and up to 2 weeks, and it could be longer. So by then, they could be having all of the calling cards of the complications related to COVID without actually having virus present in their system for a myriad of reasons. So that makes the testing sort of a lot less accurate, because the nature of the virus itself isn't as such. But patients who are initially having symptoms and we test them within 2 to 5 days of the onset of symptoms, we're capturing a lot more cases than those who are testing 10, 12, 14 days out. And we're also, there's definitely a healthy amount of skepticism from New York and my colleagues, because of what we went through in our peak. We see a patient, we think they have it, and they have all the calling cards. We're like, no, they can't be negative. We just went through all this. We'll test them again. It's like, well, it's not as prevalent now, so now we have to be a little more accustomed to thinking about other things. So I think it's a mix of that. But on a large enough scale, it should capture enough people who are early symptomatic as far as the viral testing is concerned. The antibody testing, we'll see if they find some uniform testing protocol that they're able to distribute to everybody and make it streamlined so we can all relate to how it's useful. But right now, there's too many variables to reliably say that a true positive or a true negative is that, and B, if it conveys sort of a get out of jail free card, that people are not going to get sick and have full immunity. And if that immunity is eternal. Other coronaviruses such as SARS and MERS show that immunity waned after about 3 years. So it's likely, even with vaccine development, it's remains to be seen, and I'd say unlikely that it's something that's going to be a one and done type of deal. But that's all speculative from me.
We've heard a lot about the demographics of folks who are commonly affected, whether it be the immunosuppressed or the elderly. One of our guests was curious to know if there were any other particular communities you've learned about over the last couple months.
I find that the highest degree of morbidity and mortality falls almost uniformly along socioeconomic lines. And I think that's not necessarily because of their pre-existing conditions. And there's always, we can always highlight the fact that, patients with poor health access in the beginning and less means likely have poor health outcomes. But, there's a multitude of factors, because not only are they in environments where there's a higher degree of inoculation, they're less likely to have appropriate social distancing because of their jobs and the circumstances in which they're living. They also, frankly, have access to inferior medical care when they do seek out medical care. My time with my colleagues at Elmhurst Hospital, which is that I mentioned, the safety net hospital in Queens, their mortality rate was high above just the total average of what's been conveyed, and that's purely the fact that the patients who often were uninsured, who were immigrants, who didn't have the same access to primary care and comprehensive medical care as many Mount Sinai patients did, were receiving care at hospital centers that weren't equipped to care for them. So that's definitely something I find is the most sort of striking shift in things that I've seen, both anecdotally and based on data that's been published. But as far as medical comorbidities are concerned, generally, if people have pre-existing lung conditions, generally if they're older, if they have diabetes or high blood pressure, they tend to have worse outcomes, but it's all relative, because everyone who's worked on the floors can speak to a patient who came in without any past medical history, who's young and healthy, who ended up in the ICU, or a patient who was elderly with a million medical problems, who walked out of the hospital after 2 weeks. It's unfortunately hard to pinpoint anyone who's particularly at risk, which is why it's challenging to develop policy and develop actions to sort of target people who may be more at risk. Because while it's definitely true that young people are more likely to do well and do better and not have catastrophic outcomes, it's not uniform. Initially, we thought children were basically unaffected, but now there's this new inflammatory syndrome that's starting to pop up that we're seeing. It's extremely, extremely rare, but it's present and it exists. So I'd say aside from from the actual medical standpoint of what preconditions there are, I can't really say that there's anything that's uniform. But I would say from my experience, the socioeconomic disparities is really where it cuts for who tends to do better and who tends to do worse.
I'm going to ask you a question that's not exactly towards your expertise, but you're certainly working in the trenches. Anybody who watched the news over the last couple of days saw the images of packed beaches and restaurants, and you kind of mentioned that. And having yourself been so involved in the virus and infected yourself, what do you think about how we can go about convincing the public to take the virus seriously?
Oh man. So it's interesting because I'm in New York and people get it here because there's hard to find and there's no more than 1 or 2 degrees of separation from people here who knew someone who had a horrible course or died from it. It's hard because people going out in the summertime, there's definitely age ranges, and people of my demographic, age-wise, are more inclined to not think it as serious because we're not as affected by it. What is effective? I don't know. It's something that I really wish I had more of an answer towards. I mean, the grim answer is, anyone who has someone who they know or a loved one or has spent a day doing what I've done or what I did will take this seriously. But numbers are just numbers without the association to the actual lives behind the numbers. And if it's just conveyed as a statistic, it's eventually just people just become numb to the number. 100,000 people is not, I thought it was interesting what the New York Times did last Sunday. We're actually trying to make that more of a tenable thing to show what these numbers represent. But even so, they're just individuals on a piece of paper. It's hard to convey sort of the difficulty and how hard it was and what we went through without being there or be affected by it directly. I wish I had a better answer. I think there's sort of a collective inertia that people are trying to overcome because they've done all these things and they themselves felt fine and haven't had any experiences with this because they frankly work, and it worked, and it's great that people were staying at home and were generally unaffected by this, especially California, which based on the population tremendously bucked the metrics of what was anticipated. And that's definitely a testament to the measures that were taken. But now that we were 2-3 months in and we see, oh well, this wasn't nearly as bad as what it was, it's a fallacy to think that it's because it was all overblown. It's because what we did was working. And so the unfortunate truth, I think, is it has to hit people personally, and it has to be something that's conveyed personally, and it has to be something that's taken seriously from the top down as sort of a effort that is the be all end all as far as its importance. But there also needs to has to be buy-in from people, and it's hard to force that.
Thanks for that. So kind of in looking to wrap up, I want to kind of try to bring it back to your own career and your own path. And maybe kind of start with a question about asking how your time at Milken and maybe even your time as a young adult influenced your work and maybe your response to the crisis.
So I think the one thing that I've always been proud of is just the community I was raised in and everyone I've interacted with, and sort of has given me the tools to be compassionate, understanding, and listen to people, and also think critically and independently of what I've been given. And I think how that's helped me now, and sort of motivated and pushed the way I practice in the very short time I've actually been practicing, is considering the human aspect of what I'm doing and considering how the treatments I'm giving, I'm operating from a position of a knowledge disparity, and for me, it's routine. When a person's in the hospital, I do this every day, but that person and that family is going through the worst thing they've ever gone through. And having that recognition sort of stems from just coming from somewhere that always emphasized humanity and critical thinking and consideration of others, and having sort of your feet on the ground and having a grounding in morality and recognizing that there's greater good in things that we do, and from a myriad of places. And I'm not just saying that because all my entire family's on the line right here, so they can pat themselves on the back, but I think that's definitely something, and it's definitely influenced my sort of immediate career choices and things that I'm hoping to pursue. I decided I wanted to go into pulmonary and critical care medicine before this pandemic hit, which was perfect timing that a viral respiratory pandemic happened right when I decided to do ICU medicine. But it hasn't wavered that. And a big component of soon to be research projects and things that I'm working on are very focused both in education and in palliative care, and the way that we communicate with families in the ICU are projects that I'm sort of starting to formulate. So it's all, it's all a byproduct of my, LA Judeo Milken Ramah community upbringing. I think as it's all relative. It's actually, I haven't thought about it in that way. So this is nice to sort of bring it all home for everybody.
You're welcome. One of our guests did want to ask about if you have plans to specialize in something or do fellowship down the line.
Yeah, I'm going to pursue pulmonary critical care, which is, I think it was something that I was very interested in before. It's something that I had a lot of exposure to growing up in my family, both having a parent who did that very thing, but also, it's something that I've gravitated towards as just what interests me. But I see myself in more of the academic sphere, mainly from the educational side, working with trainees, both at the MD and the medical student level. But I'm thrilled that I'm no longer an intern in a month. I'm actually going to be unceremoniously promoted, with getting some more responsibilities. So I'm trying to just take it one day at a time. But that's sort of the big picture, long game for me.
Great. So I guess I'll end with one last question. First, I'll say how proud we are of you and all the work that you're doing. I've been listening, and I think it's pretty cool. We've had an hour-long private tutorial about everything that's going on with our own private resident physician. So it's been so exciting for us. As we embark on the summer and see more reopening happening across the country, might there be a tip or two that you would have for us as we kind of head into this next stage of the virus?
Yeah, many actually. I think a lot of the things that's been promoted are always good best practices. The mask wearing, I actually think, is something that's extremely important, not because of it as a means of protecting yourself from the virus. It's only partially effective in that way. But if and when somebody does have symptoms or is exposed, it significantly reduces the degree of exposure that they can have to the community. And if everybody is wearing masks and everyone's mitigating their own exposure and the exposure for other people, that can have significant effects. Continuing to wash your hands, continuing to, do these basic hygienic practices. I've been getting in a lot of flack because I'm a chronic face toucher. So I'm getting into the habit of not doing that, and then also washing my hands and sanitizing my hands after that. But also, being responsible and proactive in the activities that you're doing and the things that you're going out to do. I think that it's not, I'm someone of the belief that we don't necessarily have to be bunkered down and sort of distant from one another. It's important to have that kind of social interaction with people, but as long as you're maintaining distance, avoiding sort of handshakes, and it's hard to not want to hug somebody you haven't seen in a long time or a loved one, but even if you're 110% sure that they don't have it and their exposures are risk, like there's just unfortunately no way to know. So I would say not inhibit the day-to-day routine, try to modify as much as you can to get outside, to do the things you normally would do. But also recognizing that this is, unfortunately the perfect storm of a virus because of its asymptomatic carrier rate and of how infectious it is. And there's simply no foolproof way to feel 110% confident that you're not going to be exposing yourself or others. So I would say, adhering to whatever guidelines are out there, being responsible and respectful of other people, washing your hands, wearing a mask, keeping your distance, and just avoiding large crowds for now are really all that you can do. But I don't think that's something that, comes without no risk whatsoever.
Well, on behalf of everybody who tuned in, I want to thank you so much for your expertise and your willingness to share with us. Your families on the call, I want to thank them for everything they did in raising you and helping you become who you are. And it's really incredible to hear from you and to learn from you. So on behalf of everybody at Milken and the alumni community and the alumni parent community, thank you so much for everything that you're doing.
Thank you. If Ross is okay with me, if you want to put my email in the chat, if anyone has any further questions or any things that come up or any, dilemmas as far as, from the medical side of things, or just wants to be inundated with medical literature that I have piles of, I'll be happy to provide whatever I can. Scheduling and, now that my schedule is about to explode, withstanding, but I'll do my best to respond to whoever has questions.
Thank you so much. For all our guests, I just shared with you Aaron's direct email line. Be kind as you write to him with all of your one-on-one questions. I apologize for the questions I could not get to, but thanks everybody so much for joining us, and be safe and be well and have a great evening.
Thank you, Aaron.
Thank you. Thank you, everybody. Thank you for coming.
Thank you, Aaron.
Thanks, Aaron.
You're welcome, Mom.
Thanks, Aaron. Well done. Well done.
Aaron, that was
Thank
awesome.
you.
Have a good night, guys.
All right, we'll talk to you later. Bye.